Hello, my name is Ifeyinwa Okeke, and I will be presenting case 3. The introduction of the case is as follows. EM is an 82-year-old Hispanic female who was brought to the emergency room today by an ambulance with a chief complaint of palpitation and dizziness. Her history of present illness: her daughter claimed that EM has been having unstable balance when she attempted to rise from the table after lunch and feels her heart racing and dizziness. This has been going on for a few weeks per the patient, but the daughter claimed that this probably has been going up for the past year, and they attributed it to her sour stomach and age. Patient also reports to feeling chest tightness or burning early in the morning before breakfast, but this chest pain she is currently feeling makes her feel like her heart is racing faster than before. On arrival to the emergency department, the patient is still experiencing palpitation and feels lightheaded. Her past medical history is significant for hypertension and dyslipidemia. Her social history is non-contributory. For drug allergies, the patient is allergic to clarithromycin, from which she experiences itching and rash. Her current medication list includes rosuvastatin 20 mg by mouth daily, aspirin 81 mg by mouth daily, lisinopril 10 mg by mouth daily. She chews 1 Tums as needed for stomach upset. She also takes multivitamin gummies once by mouth daily, and she prescribed St. John's wort, which she takes daily by mouth for depression. Her prioritized problem list: for high priority, I have atrial fibrillation and H. pylori. For medium priority, I have hypertension and dyslipidemia. And then low priority, depression and hyperglycemia. The assessment of the disease: chronic uncontrolled atrial fibrillation, as evidenced by patient heart rate of 134 at the emergency department, an EKG reading showing irregular reading. Patient reports of feeling palpitation, heart racing, and chest pressure for a few weeks. Contributing factors includes patient age and sustained left ventricular hypertrophy, likely due to chronic hypertension and aortic regurgitation, as seen on the echo. The goal of therapy is to control ventricular rate, since patient is hemodynamically stable based on the recent AHA, ACC, and HRS guideline, and the long-term antithrombotic agent to reduce the risk of stroke. H. pylori infection was also noted in this patient, as evidenced by a positive urea breath test. The American College of Gastroenterologists recommends H. pylori eradication to promote ulcer healing and symptom relief. The patient has been compliant with her previous therapy and is willing to adhere to the recommended therapy. Assessment of patient's current therapy: patient is currently taking rosuvastatin, aspirin, lisinopril, Tums, multivitamin, and St. John's wort. This therapy by the AHA, ACC, and HRS guidelines for the management of atrial fibrillation, and the American College of Gastroenterology guidelines for the management of H. pylori is inappropriate. For AFib, The AHA/ACC/HRS recommends the use of beta blocker, a non-dihydropyrimidine calcium channel blocker, or digoxin, as initial therapy to achieve adequate ventricular rate control. Level of evidence B. Also, chronic anticoagulation therapy is recommended in patients with CHA2 VAS score of greater or equals to 2, as is the case with our patient. The level of evidence is 1A. This decreases the incidence of stroke by up to 70%, and the recommended antithrombotic agent to use is factor 10A and thrombin inhibitors are preferred agents for hemodynamically stable patients. For H. pylori, the American College of Gastroenterologists recommends an antibiotic therapy for all H. pylori eradication, and a 4-drug regimen is associated with up to a 90% eradication rate. For the plan is to discontinue patients' aspirin, discontinue Tums, discontinue lisinopril, and discontinue St. John's wort, and initiate metoprolol tartrate at a dose of 2.5 to 5 milligram IV bolus over 2 minutes, up to a maximum dose of 3 doses. For maintenance, we should initiate 25 milligram metoprolol tartrate by mouth twice daily, and if no response, or if the response is suboptimal, the dose should be titrated up as needed, up to a maximum dose of 400 milligram per day. This is per the AHA, ACC, and HRS guideline. I chose a beta blocker because different trials have demonstrated the efficacy of beta blocker in decreasing rate control in patients with AFib. One of such trial is the AF/CHF sub study, which demonstrated that beta blockers significantly lowered mortality but not hospitalization in patients with AFib and congestive heart failure. Also, the sub-study of the retrospective cohort study, the AFTER trial, AFTER stands for atrial fibrillation in the emergency room. This trial demonstrated that in matched emergency department patients who were not undergoing a rhythm control strategy, administration of a beta blocker was associated with lower hospital admissions compared to calcium channel blocker, but no difference in emergency department length of stay. For monitoring, patients on metoprolol should be monitored for their heart rate. ECG should also be monitored. Blood pressure should also be monitored. This is for patients who are on IV administration. And for patients who are on oral administration, we need to monitor the heart rate, the heart rhythm, and the blood pressure. Also, the patient needs chronic antithrombotic agent. So the patient needs to be administered apixaban 2.5 milligram by mouth twice daily. I chose this dose because the patient is greater than 80 years of age, and per the AHA and ACC/HRS guidelines, patients who are greater than 80 years of old should be started with apixaban 2.5 milligram by mouth daily. I also chose this regimen because a lot of studies has demonstrated the efficacy of apixaban in preventing ischemic stroke in patients with atrial fibrillation. One of such study is the AVRIO study, And this study was prematurely terminated due to the superiority of apixaban when compared with aspirin for preventing the occurrence of any stroke or systemic embolism, while bleeding risk between the two treatments were similar. For the monitoring, patients on apixaban should be monitored for their renal function, the CBC prior to initiation and when clinically indicated, and at least annually in every patient. For H. pylori eradication, the following therapy has to be initiated for 10 to 14 days. Bismuth subsalicylate, 525 mg by mouth, 4 times daily. Metronidazole, 250 mg by mouth, 4 times daily. Tetracycline, 500 mg by mouth 4 times daily. Ranitidine, 150 mg by mouth twice daily. Per the ACG guidelines for patients who are allergic to penicillin. And this has a 75 to 90% eradication rate. I chose this regimen because my patient is allergic to clarithromycin, and this regimen also has a very high eradication rate. If after therapy with this regimen and the patient is still experiencing dyspepsia, the patient should be retested for H. pylori after 4 weeks, and if still positive, should be retreated using a regimen that contains antibiotics that are not included in the previous regimen used. For the monitoring, for tetracycline, we need to monitor the renal, hepatic, and hematologic function, temperature, white blood cells, appetite, and mental status. For ranitidine, we monitor the AST, ALT, serum creatinine, occult blood with GI bleeding, signs and symptoms of peptic ulcer disease. For metronidazole, we monitor the CBC differential at baseline, during and after prolonged or repeated course of therapy. We monitor the LFT, observe patient clearly. If neurological symptoms occur, we consider discontinuation of therapy. For non-pharmacological intervention, this includes patient education. We educate the patient to take the medication exactly as prescribed. Patient needs to decrease the intake of sugary drinks like soda. Instead, should be advised to drink water instead. For apixaban, the patient should be advised to take the medication without regards to meals. Patient needs to discontinue St. John's wort because this decreases the serum concentration of apixaban, predisposing the patient to stroke. Patients should also be consulted on the need to avoid taking grapefruit or grapefruit juice, as this increases the serum concentration of apixaban, predisposing the patient to bleeding. Metoprolol can be taken without regards to food, either with food or immediately following a meal. With regards to vaccination, based on the patient's age, patient requires annual influenza vaccine, pneumococcal vaccines, and shingles vaccines. Thank you.